We're going to do this in two parts. First, I'm going to give some brief comments, kind of an overview of all things dementia and Alzheimer's. And then Dr. Abindente and I were going to moderate an extensive question and answer discussion, and you can ask questions and we can ask each other questions. First thing I want to tell you is that everybody asked me the difference between Alzheimer's and dementia. Is somebody going to ask me that? That's the difference between cancer and breast cancer, or cancer and prostate cancer. Cancer is a category, prostate cancer or breast cancer is the type. Dementia is the category, Alzheimer's is the type. Dementia just means that your memory loss is so bad that you've lost your independence. Dementia is a category. So many things cause dementia. Parkinson's can cause dementia. If you follow dementia in Parkinson's, up to 2/3 of people will develop dementia in their lifetime. Lewy body dementia, water on the brain, stroke, so many things cause dementia. They don't cause Alzheimer's. Alzheimer's is a kind of dementia, but so is Lewy body dementia. So understand category and type. So the reason I'm telling you this is that we're moving toward a biological definition of Alzheimer's, and we now have new staging criteria for Alzheimer's disease. And the first several years that you're developing changes in your brain are times, just like Parkinson's, that you have no symptoms. Your disease is developing in your brain, and then you develop memory loss, and then you develop full-blown dementia. Okay? So there's a new staging scale for dementia, for Alzheimer's disease, and up to 20 years before you ever have a day of forgetfulness, you've accumulated the changes in your brain. Now, it used to be, and sometimes some places in the valley still, you go to the doctor, you say, I have a memory issue. If you're fortunate enough to go to a doctor who pays attention and doesn't dismiss you and say, don't worry about it, we're all getting old, or don't worry about it, we're all forgetful, or don't worry about it, you're just stressed out and you can't sleep. If you have the fortune to see a doctor who knows what they're doing, you need to understand that historically, they would check your MRI for stroke, they would check your thyroid, they'd check your B12 level, and say everything is fine. And that was the clinical description of how we approached a diagnosis. Turns out to be grossly inaccurate, somewhere between 2/3 accuracy, just based on excluding other pathology. And so what the field has done in a very aggressive way is moved away from excluding other things to diagnose it with precision. And now we have a specific model called the ATN model, amyloid, tau, and neurodegeneration. We can take blood tests, spinal fluid, and PET scans and diagnose Alzheimer's disease with about 95% accurate. This is not research. Don't believe Dr. Google all the time. Dr. Google's not my friend. I am telling you now, in 2025, we have the ability to diagnose Alzheimer's disease with 95% accuracy with blood tests, spinal tap fluid analysis, and PET scans. So that is where we're at. So let me kind of give you the crash course on the field. And so the first thing we need to know is that we used to look at MRI and say, okay, MRI, there's no stroke, tumor, and water on the brain. That's how we looked at MRI, no stroke, no tumor, no water in the brain. Now we're looking at it in terms of white matter disease. We can measure specific areas of the brain. We have a technology called volumetric technology, and we can measure the shrinkage of specific areas of the brain. And when we worry about Alzheimer's, we worry at a very specific area called the hippocampus. And when that shrinks a lot, there's a chance that they're developing degeneration, which could be a marker or indication of Alzheimer's changes. The other thing we always do now is we can look at PET scans. PET stands for positron emission tomography. Sugar PET, which is not this PET, sugar PET is what you use in cancer. So if any of you had ever cancer and they ordered a PET scan on you, they're looking for sugar metabolism, because if it's hot, lights up, that means there's cancer. We're talking about the same machine. We're injecting something different in the arm. We can look at your brain to check for amyloid. Okay, amyloid is the marker of plaques. So when you hear about plaques and tangles, we can now measure plaques in your brain in ways that we never were able to do before. When I talk about my colleague, Professor Paul Coleman and I, we were the first people in the world to do this in Sun City, Arizona. And so I can tell you we were very early involved in this development program. And this is approved now. These are not research. This is approved. There are 3 technologies, fluor beta bain, Florbetapir and flutamidamol. In fact, one of the vendors, GE, is Vizamil, that's flutamidamol. They're sitting right outside here. And so what I'm saying to you, and Lilly has the florbetapir Amivid. So these are technologies that are approved. The doctors can order them, and they have very tremendous accuracy in detecting Alzheimer's pathology directly. What about spinal fluid? Now, I hear a lot of people say, ooh, wow, that seems awfully invasive. Why would I do a spinal tap for a diagnosis of Alzheimer's? And I say to you that spinal taps are done for meningitis, encephalitis. If you go to the hospital with a fever and a headache, you hope they're doing a spinal tap to diagnose your meningitis, encephalitis, because if they miss it, guess what happens? Your brain is cooked. So that's what I'm trying to say is that we're doing spinal taps anyways for a lot of different reasons, for a lot of different conditions. There's no reason we can't do spinal taps for Alzheimer changes. And it's very, very accurate, about 97% accurate. And if you don't believe me, I want to point out to you that if your amyloid is down and your tau is up, you have Alzheimer's diagnostically. And if your amyloid is down and your tau is up, the chance of you getting worse is about 90% in 5 years. So what I'm saying to you is that it's very diagnostically accurate and very, very, very predictive of future decline. And so we actually have spinal fluid, commercially available, not research, been approved. You come to my clinic at the Barrow Neurological Institute, you know, if we're not doing PET scans, we're going to do spinal taps. And so this is commercially available. What about blood tests? There are blood tests. They are approved. They are available. Most doctors are completely unaware of them, but they are available and they are approved. So the first one is amyloid. We can actually measure blood amyloid. And what happens in Alzheimer's disease is that it's sucked up into the brain, so your amyloid levels in your blood start to go down. And we measure a ratio of amyloid to tau. And in fact, if you read the news just last week, Fujiribio got the FDA approval for phosphorylated tau to amyloid ratio as a blood test. It is now available. And what happens is that the ratio starts to go up because your tau levels go up and your amyloid levels go down. And so this is now available. Every time a company says, Dr. Sabbagh, will you start ordering my blood test? And that happened this week, LabCorp. I said, give me all the codes. So in our world, Dr. Evidente, in my world, it's not about the tests we order. It's about what will Medicare pay for? What codes will Medicare pay for? And it's funny because I asked her that question and she hasn't gotten back to me. I'm like, give me the codes. Otherwise, I order it and you'll get a big bill. And then you call my office and complain, oh my goodness, why did you order such an expensive test? It's all about the codes. Got me? So the other blood test is called p-tau. P-tau. P stands for phosphorylated tau. And there are two p-taus. One is 181 and one is 217. And p-tau levels start to go up. Why? Because tau is remember we talked about plaques and tangles? Plaques is amyloid, tau is tangles. Okay? Plaques and tangles, right? Plaques is amyloid, tau is tangles. Tau levels go up because your brain, tau is a marker of injury of the brain. When your brain is injured from Alzheimer changes, the tau levels go up. And so we know that there are two kinds of proteins of tau that go up. One is 181 and one is 217, and they're extraordinarily accurate. If your level of p-tau is above a certain point on the blood test, the probability you have Alzheimer changes in your brain is about 96%. To the point where we are thinking maybe in the future, we don't need PET scans, we don't need spinal taps, we will just be able to do a blood test and be able to diagnose or predict Alzheimer change. We're gonna have a question and answer session. Write it down. Got it written down? We are gonna have plenty of time for questions. I wanna say I see several people in this audience that are my patients or related to my patients. Hello to all my patients and the relatives of my patients. So I want to say that to you guys. But 96%, one day we might be using these tests only without PET scans and spinal taps. The question that we're actually asking ourselves is, if you're in middle age and your p-tau levels go up, is it predictive that you're going to develop Alzheimer dementia? That question is being very, very openly asked. And the answer is, we will see. Those studies are going on right now. There are people that are already proposing the idea that when they're checking your cholesterol and thyroid and homocysteine and your B12 level, they'll start checking your amyloid and tau to see if you're going to get Alzheimer's in your future. That is not practiced. Do not go out and do that yet. We don't know, but that could be the future. A lot of people are saying, could we predict people? Because we'll tell you something now, is in my clinic now, I have a lot of people who are memory tests are normal, but their blood tests are abnormal and their PET scans are abnormal, so they're at risk for developing Alzheimer's dementia. There is a genetic test called the APOE genotype. I would have said 23andMe, but they went bankrupt, so I can't recommend 23andMe. We know that if you're an APOE4 carrier, your risk of developing Alzheimer's disease is some between 3 times above the general population or 12 times above the general population. We know that you have memory issues and you're an APOE4 carrier, you have about a 94% probability you have Alzheimer's changes in your brain. And we know that it's highly predictive of future progression. We do not use APOE genotyping as a diagnostic. We do not. Very important. We do not use it as a diagnostic. But now that we have these new anti-amyloid therapies, which I'm going to show in the next few slides, we have to use the APOE genotype to predict whether you're going to have complications from the new treatments. So we're now using it for what's called risk stratification. So the reason I'm saying this to you is some of you have memory issues. Used to be you go to the doctor, complain about it. Like I said, hopefully they're taking you seriously, not dismissing you. And if they take you seriously, again, they used to check a B12, a TSH, and an MRI. That's the past. The present is we have blood tests. The future is you have a memory issue, you make an appointment with somebody like me, we send you a link, you take a memory test on your phone. That link goes to our computer. That link then says you're flagged. You have probably an Alzheimer risk profile. We'll order the blood test even before you walk in the door, and we will be able to diagnose you in a matter of days to weeks, not months to years. The typical diagnosis of Alzheimer's, which is true for a lot of Parkinson's people, is it can take 6, 12, 18 months to get a diagnosis. Same in Alzheimer's. So we will be able to use blood tests and apps to be able to predict things, and we'll be able to do it in days to weeks. We'll talk briefly about the new approved treatments for Alzheimer's disease, and it's important that you understand that we know plaques and tangles, amyloid tau, plaques and tangles. There are now only 2 available, lecanemab and donanemab. These are anti-amyloid therapies. These are intravenous therapies. They remove amyloid. They do it very, very well. They do not make you better. They make you less worse. Did you hear what I just said? They do not make you better. They make you less worse. But to be clear on this, only a handful of people, not everybody gets lecanemab and donanemab. In Dr. Evidente's world, not everybody gets deep brain stimulation, right? Not everybody gets brain surgery for Parkinson's. Some people get deep brain stimulation. And in Alzheimer's, some people get donanemab and lecanemab. So these drugs are intravenous drugs. They remove amyloid. They do it very, very well. So this is lecanemab, branded under the name you know as Leqembi. This is an intravenous drug. You give it intravenous every 2 weeks for 18 months. And it showed very clearly, that's the circle right in the middle, that the people who got Leqembi were much better off, about a 28% slowing in the rate of decline compared to the people that got the purple and blue line. Now you say that's not very much, but remember this, everybody in the study is already on Aricept, Razidine, Namenda, Exelon. So this is Leqembi plus background therapy versus placebo plus background therapy. So everybody in the study was already on Aricept, Exon, Razidine, Namenda. So this is in addition to showing about a 28% slowing in the rate of decline, and removed amyloid about 80%. The placebo group is the blue line. The orange line is the treated group. So removed amyloid did it like gangbusters. People always ask me, so why is it not 1-to-1? If I'm removing amyloid 85, 88%. Why am I not getting an 88% slowing in the rate of decline? And the answer is plaques and tangles. This is plaques. This isn't tangles. We don't have a good treatment for tangles, so you're only taking care of part of the story, and that's why it's not one-to-one. Follow me? Okay. So this is activity of daily living score showing that a slowed rate of decline, loss of independence by about 40%. This is a very complicated slide. Let me tell you why I like this slide so much. Everybody who started at the beginning of this study, we do a rating scale called the CDR, and we're saying to you that if you were in mild cognitive impairment, meaning pre-dementia, we want to know how many of you had progressed to dementia by the end of the study versus stayed in mild cognitive impairment. And what we say here is that the Leqembi people, 30% of them were, fewer percent of them were in dementia at the end of the study compared to the placebo group. So it actually, fewer people had gone on to dementia than people had stayed in mild cognitive impairment compared to placebo, and that's why this is a very compelling study. Donanemab, also branded under the name Kisunla, shows you, again, the bottom shows you their amyloid is full of brain, placebo, their brain is unchanged, and the patient B here, brain cleared out of amyloid. You see the red is gone. And it showed that, again, in about 28%, slowing in the rate of decline, also on background therapy. This is people who got donanemab or placebo. Again, everybody is on Aricept, Exelon, Razodine, Namenda, and either they got donanemab or placebo, and it showed slowing by about 28%. And we think this might work. Why does it work? Because removing amyloid, the brain likes it when you remove amyloid. It's a toxic thing. It's a protein your brain doesn't want to have around, and therefore your levels of marker of injury, I talked about p-tau as a marker of injury, and that slows the rate of decline. Now I'm going to shift gears. Again, what we're going to do is the first half of this is a brief lecture. I cut it literally in half. This was a way longer lecture. And now we're going to talk about prevention. So I want to comment on, did you guys read the New York Times 2 weeks ago when they had that whole front page about Dr. Bredesen and so a lot of people want to prevent Alzheimer's and want to diet and exercise their way out of Alzheimer's. I love that story. It's a great story. The question is, does the science back it up? Why? Because the number one thing people are afraid of is Alzheimer's. Sorry, Dr. Evidente. It's not Parkinson's, it's Alzheimer's. They did a survey of oncologists and said, what are you afraid of most? Alzheimer's, not cancer. They did a survey of baby boomers. What are you afraid of most? You guys are all baby boomers. Sorry about that. It's Alzheimer's. Okay? That's the thing that people are afraid of most. And there's a good reason for it. It affects 7 million Americans. It's the number one reason people are in long-term care, and billions of dollars are spent caring for it. And people say it's the number 6 cause of death. Now, people ask me all the time, how do you actually die from Alzheimer's? And the answer is, you might be in the bed because you have Alzheimer's. You might die from pneumonia or infection or bed sores or UTI, but the reason you're in the bed to begin with is Alzheimer's. It cuts your life expectancy in half, okay? So Alzheimer's is this, and you look at autopsies and death certificates and all kinds of studies show it's the 6th leading cause of death. Now, understand what I said before, I'll say it again, is that you suddenly don't develop symptoms of memory. By the time you walk into my clinic, you've been accumulating those amyloid and tau, plaques and tangles for 20 years. The memory loss is the end of the disease. The dementia is the end of the disease, not the beginning of it. Okay? So we know now, we hope that we can predict people who are going to get it. But we know that you go through a stage where you're still technically normal, but the disease is starting to accumulate in your brain. And that's why there's an interest in seeing if those biomarkers can predict who's going to get it, symptomatic disease. So we understand that dementia is the end of the disease. Dementia is the dependent phase. Okay? I'll give you this in a Parkinson's paradigm. Some of you have a little bit of tremor, fully independent. You're playing pickleball like was just announced. Some of you are in a walker, have dyskinesias, are forgetful, having all the complications of Parkinson's. Both of them are Parkinson's, right? One's a little Parkinson's, one's a lot of Parkinson's. Do you follow me? Same. Dementia is the end stage. It's when you're no longer independent. When your family members or loved ones or caregivers have to now help you with independence, right? Driving, finances, supermarket shopping, managing your personal affairs. That's the mild dementia. Moderate is needing a supervision with personal care. And then severe dementia is the end of life aspects. And I tell you this because dementia is the dependent phase. It's the advanced state phase. You go through accumulation of pathology, then you get a little forgetfulness called mild cognitive impairment, and then you progress on to dementia, which is the advanced phase. I tell everybody my goal in life is to work myself out of a job. I don't want to see anybody get dementia. And yet I unfortunately have job security for the foreseeable future because there's a lot of dementia. And so we understand this very, very well. Now, I know I'm in Fountain Hills. Dr. Coleman and I know each other because we worked in Sun City, Arizona, which is the Fountain Hills West, right? Sun City. I loved working in Sun City. I loved it. But people laugh off the beginning of memory issues. Yeah, I can't. The whatchamacallit, the buddy, the hey buddy, right? The word finding, the little tip of the tongue thing. Everybody does that. Like, yeah, we all do that. We all remember trouble with names. The question is, when is it noticeable? When you're repeating yourself, gee, Dad, you just said that thing 4 times in the last 10 minutes. That's not normal aging. So there is a difference between normal aging and the beginning of an Alzheimer process. But I will tell you that a lot of people kind of laugh it off, shrug it off, saying, really, there's nothing to worry about until it gets quite advanced. So if you're worried about it, or you're worried that your spouse is developing it, don't wait. Go see a doctor, come see us at Barrow. Don't wait. So I want to say to you that your brain here shows the hippocampus. This is the medial temporal lobe. This is where we store short-term memory. This is a nice and normal looking one. You see severe degeneration of the brain. That's an advanced state. We want to make sure you stay here and not get to there. And so we understand that, as I said before, the pathology changes occur before the symptoms. So amyloid, by the time you come to see me in the clinic, your brain's full of amyloid. Your brain starts to develop tau. Tau entangles, correlates with progression, and then your brain starts to degenerate, and then you get the memory symptoms. So again, by the time you walk into our clinic, chances are you have a lot of changes. So don't wait. So what are the risk factors for Alzheimer's disease? Unfortunately, the first thing is age. The older you are, the more the risk. At age 65, it's 1 in 20, and by age 85, it's 1 in 3, and by age 90, it's 4 in 10. It's not rare. It's common. It's very common. So again, age is the #1 risk factors. Family history is a first-degree relative doubles or triples your risk of developing Alzheimer's disease. The APOE genotype we already talked about. We did talk about female gender. So women, it's a plain fact that women get more Alzheimer's than men. About 60-40, maybe 2/3, 1/3. And it is also a plain fact of medicine that women outlive men. The life expectancy of a woman is about 5 years older than the life expectancy of a man. And even when you factor in the life expectancy, women get more Alzheimer's than men. And so women are more at risk. And so we understand that first-degree relative doubles or triples your risk. We understand that heart conditions, heart disease, cardiovascular disease, high blood pressure, diabetes, cholesterol, increased risk for Alzheimer's. Yeah, you're like, this sounds like a risk factor for stroke or vascular disease. And the answer is yes, and it's a risk factor for Alzheimer's. Each one of these has been independently shown to increase your risk for Alzheimer's disease, separate from vascular disease. So these are independent risk factors. And then, of course, what I call cognitive killers. In the elderly, I worry about substance abuse, drinking, and mood. There are 3 existential threats to aging. Actually, this is my next book that I'm writing right now. The 3 existential threats are falls, social isolation, and dementia. Those are the 3 existential threats to aging. That's why this community center is so important. If you come to the community center and you stay off the floor, and you become socially engaged, you're less likely to be depressed, you're less likely to be socially isolated, you're more likely to take up pickleball, and you're more likely to be active. So my point is that We don't suddenly age. It's a continuous thing. We get there. But to avoid the existential threats of aging, falls, social isolation, and cognitive issues, avoid the cognitive killers. High blood pressure is one of the things you can do more than you think to aggressively manage your blood pressure, and will lower your risk of strokes and heart attacks. Add Alzheimer's onto that list. Aggressive blood pressure management lowers your risk of Alzheimer's as well. And so that's one of the recommendations we have to people when they say, gee, doc, what can I do? Of course, the three things are cognitive stimulation, brain games, physical exercise. I love the pickleball idea, and blood pressure management. The National Academy of Sciences, Medicine, Engineering recommended those three things before anything else. Blood pressure management, physical exercise, cognitive stimulation. And so you need to understand checking your blood pressure, managing your blood pressure is good for you for a lot of reasons. Now, the APOE4 that I've already talked about mechanistically is related to heart disease and Alzheimer's disease. And so that APOE4 is a genetic risk marker. You can actually get the blood test now, widely available, increased risk for stroke, for heart disease and Alzheimer's disease. So why did I bring up Dr. Bredesen? And the answer is very simple. People want to diet and exercise our way out of Alzheimer's. That's the brain health, the mantra of brain health. I love the idea. I love it so much, I wrote 2 books about it. I love the idea of brain health, right? You exercise, you eat right, you manage your blood pressure, you sleep well, all those great things can you actually prevent Alzheimer's from developing? And the answer is somewhat, maybe. The data is not as good as it was. It's mixed. I just mentioned the National National Academy of Sciences, Medicine, and Engineering recommends for brain health management, blood pressure, cognitive stimulation, physical exercise. Then you believe CogStim is mahjong, bridge, word puzzles, crossword puzzles, etc. That's CogStim. When you believe the Lancet Commission expanded those 3 things to 9 things. Okay, and we talked about physical exercise and socialization, right? That's the Lancet Commission. But I love, Dr. Evidente, that you have hearing assistance for your population. That is awesome, because it turns out that sensory impairment augments cognitive decline. I want to be very clear that hearing loss does not cause cognitive decline, but people with sensory impairment have worse cognition because they have less sensory input. So one of the focuses now is get your hearing better. Simple. Get your sleep better. Simple. Okay, manage your health conditions. These are the 9 things you can do. And this is a study that was done in Scandinavia called the Finger Study, where they gave you aggressive medical management of your blood pressure, your diabetes, your heart disease, and you got physical exercise, and you got social stimulation. And that was group 1, and group 2 was randomized to just kind of hang in there, we'll see you later. So one group got all the interventions and one group didn't. And what it showed after several years is that the people who got this intervention, very aggressive intervention, actually slowed the rate of cognitive decline. Their memory actually got better. So the Finger Study caught national, global enterprise to the point where now there's the US version called the US Pointer Study is going on in the United States. And there's now a new study called the Finger Met Study going on. This is an area of tremendous interest. So I love this idea. Aggressive health management, physical exercise, CogStim. Great idea. Okay? It works. How much does it work? I tell you this because, like I said, I'm really so much into brain health that I wrote 2 books about it. But the answer is it helps to an extent. 2 studies just published in the last year, since I gave this talk at this community center last year, that are relevant to your conversation is, one is called the Exert Study. And what they showed is one group was randomized to physical exercise with a coach at a YMCA every day, 5 days a week for a year. And one group was randomized to go to the same YMCA and do some stretching and not physical exercise. And what it showed is by the end of the year, the people who had done the physical exercise had they had stayed stable on their cognition compared to the people who had done just stretching, which had gotten worse on their cognition. They had no decline on their cognition. But if their biomarkers that I showed you, the blood tests and scans, showed they had Alzheimer's, they still, at the end of the study, still had Alzheimer changes in their brain. So it did help from a cognitive standpoint, but your brain still, if you had a brain full of disease, Alzheimer's disease, you still had a brain full of Alzheimer's disease at the end of the study. That got a lot of attention. And then a study just published about 6 months ago by my colleague, Dean Ornish, America's cardiologist himself. Dean Ornish published a great paper, a very good study. He took patients with mild cognitive impairment, and that one group of them, he gave them their diet. In other words, he shipped them food. He had a coach. You met with the coach 3 times a week by Zoom. You got stress management, meditation, physical exercise, everything. So one group got all the interventions and one group got none of the interventions, and showed in about 75 people with mild cognitive impairment that it worked. The patients who got all the interventions, their memory got better, their mood got better, every marker of clinical outcome got better. But if they had blood tests or biomarkers of Alzheimer changes, it didn't move it 1 iota. So if you had a brain full of amyloid, at the beginning of the study, you had a brain full of amyloid. At the end of the study, if your blood test showed you had Alzheimer changes, at the beginning of the study showed that you had Alzheimer changes at the end of the study. So it helps, but it doesn't remove the disease. So when you hear my hesitation, I'm like, these interventions work, but not as much as we want. We want to diet and exercise our way out of Alzheimer's, right? I would love to, jump on a treadmill and run myself out of Alzheimer's disease. And the answer is it helps your memory, helps your health, but if you have Alzheimer changes started, if that train has already left the station, these things, the diet and exercise interventions, do not appear to impede those developments. Diets, people ask me about diets, right? Mediterranean has very good science. People ask me about keto, and all I can say is the data is good for Mediterranean and it's not as clear for keto. There's lots of studies suggesting that people who adhere to Mediterranean diets have less risk for developing Alzheimer's, and keto is very popular, right? South Beach, Atkins. I can tell you that keto is hard for people to stick to. If you do it right, if you do it properly, it's a hard regimen to adhere to, but there are studies going on whether keto makes any sense and what does brain health look like. That's what this is supposed to show, but it didn't show up. Brain health would be blood pressure management, CogStim, physical exercise, sleep management, stress management, blood pressure management. So you can actually start to create brain health to reduce your risk. Exercise is great. If you can do a few things, blood pressure management, I said so, physical exercise, which appears to work great in Parkinson's and in Alzheimer's, and reduces your risk for developing Alzheimer's and slows the rate of decline, as I said. And so there's a lot of reasons to take up exercise. I'm very fastidious about doing my own exercise every day, even though Alzheimer's doesn't run in my family. It's good for your brain. It helps a brain chemical that was actually studied from Parkinson's disease, okay? It was Parkinson's people who found about BDNF, brain-derived neurotrophic factor. And brain-derived neurotrophic factor is the brain chemical discovered by Parkinson's disease that shows healing, that if you increase your BDNF, it heals your brain cells. So I actually talked to my neuroscientist colleagues, the scientific researchers. Most of them are runners. I hate running. And I asked them, why do you run? They said the only way to get your one of the best ways to get your BDNF levels up is running. I hate running, but I've taken it up because I want my BDNF levels to go up. So physical exercise works, helps your brain. So what I'm saying is there are strategies, they work, they help your brain, reduce your risk of stroke, improve your cognition, blood pressure management, physical exercise, sleep management, stress management, diet, some diet. These things work. I would love to tell you that we can diet and exercise and brain health our way out of Alzheimer's, but the newest data suggests it's not as preventative as we would like it to be. And so we know a lot about this space, way more than Dr. Google says we know. We know a lot about this space now.